right, so this is our class about gender and sex, technically, but mostly about gender. It's another sexual variable. And like some of the others that we've been talking about recently, it's probably bimodally distributed as opposed to unimodally distributed. Let's see. So you all took the Bem Sec Roles Inventory, presumably, in class the other day. And I want to tell you a little bit about this inventory and the research behind it, as well as ask you what you scored. Something important about this inventory. It was created by two psychologists who were married and who were called the Bems. And they believed that gender was 100% constructed, and they had a cognitive model of gender. And they said that societal views about gender were transmitted cognitively um, to people within a community. And they created this sex roles inventory, is what they called it. Now, we'd probably call it gender roles today, but the way they created it was by they had thousands of items and they gave them to college students and they looked to see which ones people rated as more male or more female. Now, this is entirely by definition measuring the social construct of sex roles or gender, because it's just asking people, what do you think about it? There's nothing inherent about it. It's just what do people in a culture think about it? People often ask, is this still valid? What I have looked at in the research is that, several years after it was created, it was more valid. I mean, it was about as valid, though there is evidence that the sex roles and how people perceive them are changing and getting closer together, that people no longer associate certain characteristics with masculinity or femininity. But I wanted to give it to you. It still gets used sometimes, and as just one way to think about sex roles. We haven't talked about sex roles yet in our class, and I will do that. I'll explain the difference between that and gender and sex later on in the lecture. So for this lecture, we're going to spend some time talking about all the controversy. This class is psychology, it's not politics, but I think it's important to look at the politics because it will help you know where your feelings lie so you can understand what your countertransference is. And so I want to outline some things for you so you can put some words on maybe how you think or maybe be exposed to some new views. We'll talk about gender role, we'll talk about gender identity, what happens when gender identity and anatomy don't match, treatment for folks who are trans, and psychological ethics regarding treatment of folks who are trans. So again, a big part of being a psychologist is understanding your own personal biases. Countertransference here is one definition: the emotional reaction of the analyst to the subject's contribution. This is a very psychoanalytic explanation, but that you have your own personal issues that taint how you see the client. So it's important in analytic psychotherapy, it's important to try to understand these biases that you have. So let's look at some of the language and politics around it. Politics are huge right now. They've really taken an influence or had an influence on how we talk about trans folks and how we talk about gender. Roughly speaking, I think that the way we talk about gender and trans issues can fall into about 4 different categories. Transactivist views, those are people who sort of really are activists for trans rights and who fall very much on the side of protecting the rights of trans people. Interestingly, in my mind, because feminist views and queer views often really line up, but in this case they don't necessarily. There are some radical feminist views that are not very trans supportive, and we'll dive a little bit into that. I gave you some articles about these things for you to get a sense of what the differences are. And then, of course, there are traditional Judeo-Christian morals, which make their way into our discourse. And then there's science. your readings, you have the chapter reading, you've got two readings, one from a radical feminist perspective, one from a transactivist perspective, and then you've got the textbook reading, which is more science. I've also included a strange little article I found. It was an essay about somebody trans in Denmark and trying to go through the system here to get gender affirming surgery and some of the discrimination they felt that they came across. One of the discussion posts is oriented toward that, like how do you decide who gets the surgery, given that there's always a limited amount of resources. I will say that after all of these politics and after all of these different sort of philosophical positions, luckily as psychologists, it's not that hard to approach a client because my resolution for all this is to simply follow the client. I try to understand their perspective rather than impose mine. And I do have you'll see that mine falls somewhere in between transactivist, but a little bit toward the radical feminist uh, views. But when I see a client, I'm going to try to follow their views and also just encourage a reflective space, a place for them to think about who they are and how they feel about things without having to necessarily make a decision. Reflection versus reaction. Modern analytic approaches, such as there's one of the most modern uh, derivations of psychoanalytic theory is called mentalization theory, and that encourages curiosity, that we're going to be curious about a person's perspective. We're always going to be asking questions. I think it's fairly easy to maintain a somewhat neutral stance as a psychologist if you follow the client. So some more here about the controversy. You'll find that Dr. Rebecca Riley Cooper, she represents the more of the radical feminist approach. Her position is, and there's a quote from her article here: you do not need to be genderqueer to queer gender. The most radical approach is that we don't even want to have gender, and so if there is no such thing as gender, then you don't need to change your genitalia there's because it's just simply not an issue. Um, at any rate, I hope you have fun reading those different perspectives and you try to understand where you fall in some of that and what sense you make of it. So again, some terminology. We've already talked about what sex is. We've talked about gender is in the brain. There's also something called gender role. That's also called sex role. That's what the BEMS talked about. That's the sorts of roles you take in society. Like, are you a leader? Are you assertive? Um, are you more nurturing? Are you more dominant? Are you more submissive? Versus one thing we haven't talked about here at all is gender expression. Students often get these things confused. Gender expression has nothing to do with any of these three. It is literally, it's about what you wear and how you express yourself. So, and they're all independent, pretty much. So if you look at this picture down here, this is just out of a movie called The Devil Wears Prada. If you've seen it, this character, Meryl Streep, she's super aggressive. Um, she would score high on masculinity, probably, with gender roles in the Bem Sec Roles Inventory, but her gender expression is decidedly female. Her sex, that's what's going on between her legs. Don't know, they didn't show it. And her gender identity, I think she probably identified as a female. So they're all independent. So just to reiterate, you could be somebody who had a penis in between their legs and was assigned male at birth, but you feel like you're a woman in your brain, but you could be very aggressive, so you could take on a more masculine gender role, but wear a dress and be feminine in gender expression. So just to reiterate, this gender role or sex roles, behaving according to societal expectations about your assigned sex. This is the Bem Sex Role Inventory that you all took. They had a theory about gender role socialization. How do we know how we're supposed to become? And what they said is basically that children learn gender roles as they grow up. They learn them. They have a cognitive model of learning. Here's an example of a cognitive model here. You don't really need to know this in any kind of detailed way, but basically in a cognitive model, our brain has all these, you might even conceptualize them as neurons. We have these ideas about things like a bird. We have that when somebody says, think of a bird, you're probably going to say something really common like robin or crow, and that there is a network of ideas or concepts in our brains where certain concepts are linked with other concepts. And they proposed that we had a schema like that about gender, and that accounts for how gender roles are transmitted or taught by society. Here's an example about Santa Claus, that some things would be fairly close in that schema, and others would be further off, like Prancer would be further off. Again, it gets a little bit away from this class, but I wanted to just give you an idea about how the BIMs were thinking when they devised their questionnaire. And so what they said is that we learned how to be girls and boys, and here's an example of society trying to teach people how to be boys and girls. I mean, I understand they've changed this quite a bit. In fact, I think that Toys R Us doesn't even exist anymore. But even when my kids were young, this is what the toy aisles looked like. You were told this is what you should like. It never made sense to me, by the way, when I was growing up. I liked G.I. Joes. Um, but yeah, so this is society telling you this is how you ought to behave. So we've already talked about this. So let's talk about gender and sex and gender roles. And increasingly, this is Sasha, whose parents did not tell anybody what natal or what biological sex they were born as. This is from several years ago, this picture. Sasha has since grown up and is now identifies as a boy and is also has a penis. But the parents were pretty progressive for when they were raising their kids. Now, the thing about this came out of some sort of social media right here, this picture of Sasha. And the parents didn't even tell like the grandparents what sex the child was. Only the close people who changed the baby's diaper knew. And they let Sasha gravitate to what Sasha gravitated toward in terms of what toys he ended up playing with. Um, I when I was reading this article at first, how you sometimes get sucked into the comment section, and people were so hateful to these parents. And I mean, they wished them death for experimenting on their children. Of course, these parents, their intentions were that their child could be whoever the child wanted to be, and they didn't want people to impose these ideas on the child. So their intentions were, really good. I think Sasha turned out okay, and Sasha's now, everybody knows is a boy. But there are more and more parents trying to do this. It's very hard to do in our world. I had a friend who tried to do. She told people the sex, but she was really like, don't get her girl toys, get her androgynous types of toys. And her extended family just refused. They just made sure she got girl toys. And I mean, I think it's really hard to raise your kids in a vacuum. By the way, there are some gender nonconforming preschools or kindergartens in Sweden, so there is some support for parents who want to do this and want to give their kids a lot of freedom. How many genders are there? Just so you know, there are some countries now who recognize on their census forms that you don't have to choose male or female. You can choose other or some, neither if you want. Um, some more terms here. There is one of these that doesn't belong at all. This first top one, she-male, generally doesn't belong in these categories. She-male is usually fetishistic. What a fetishistic means is that it's something done for sexual arousal and gratification, like a shoe fetish. And most she-males usually have breasts and a penis. One of the above is surgically constructed, and they're often sex workers. They're often folks who are either in porn or who are prostitutes, and it's usually because there's a certain kind of fetish for that sort of thing. It doesn't really say anything about how they identify. Intersex is the term when you either have ambiguous or both sets of genitalia. And by the way, even biological sex isn't truly binary. There is a continuum there in size and shape. Bigender would mean somebody who felt in their head that they were two genders. Cisgender is what most of you all, if not all of you, are. We're all lucky to everything sort of matches up. And there's trans man or female to male, a little bit less used than it used to be. Trans woman or male to female. Agender, you have no gender. This last one here, TG and C, gets used a lot in psychology. It stands for transgender nonconforming. Transgender and nonconforming are a little bit different from each other. Transgender is if you feel like you were born in the wrong body, but nonconforming people are a little more ambiguous. They don't necessarily identify as any particular gender, and they actually have, if you're transgender and you can pass, that means can they tell that you're transgender, or do you, if you are somebody born in a male's body and you're appearing as female and you identify as female, but everybody thinks you're female, then you pass. Non-conforming people often fall somewhere in the middle and you don't know who they are, what they are. They actually have a harder mental health outcomes. And I think it's the non-conforming people who get stopped at the bathroom and told to go into a different bathroom. The transgender people who pass, they just go into the bathroom that they want to go into, but the non-conforming people probably have a harder time. So if we look at anatomical sex and look at the biological influences, so I'm going back to 8th grade biology here. Your anatomical sex is roughly your chromosomal sex. Remember that females are XX and blueprint for males is XY. And plus your chromosomal sex. So often what happens in that androgen bath at 7 weeks, sometimes, and also hormones later on can affect it too in some conditions. You probably remember from 8th grade biology that there are conditions that are triple X or XYY, etc., and they often have an effect on your anatomy and this sort of intersex condition. And so if females, the genetic blueprint is XX, and for males it's XY, that means the father or the mother is generally responsible for determining the child's chromosomal sex. This is, again, 8th grade biology. It would be the dad, because only the dad, again, if we're talking strict two sexes, only the dad contributes a Y. Early on, everybody's programmed for female development until that high level of testosterone at the 7th week, and then you start to see the two sets of gonads start to look different, and one develops into ovaries, the other develops into testes. So, and then here's this word that you already saw, prenatal chromosomal and hormonal irregularities can lead to development of ambiguous genitalia, sometimes called intersexuals. So gender identity, that thing in your head, we used to believe it was entirely socially constructed. We probably don't think it's entirely socially constructed anymore. Maybe pieces of it are, but even like we found out in the sexual orientation lecture, when there have been attempts to reassign gender at birth and just raise a natal boy as a girl, hoping she'd be attracted to boys, you found that you couldn't really make it happen intentionally. This is this shows the progression from the DSM-4 to the DSM-5, where gender identity disorder got relabeled as gender dysphoria. Gender identity disorder, this is how I think of it, is it tended to pathologize what was happening in the person's brain. Like something is wrong with your mind that it doesn't match with your genitalia. What we now say is that what's wrong is that you're unhappy with your genitalia. It sort of puts the pathology in a slightly different place. Rather than in your head, it puts it in your feelings about your genitalia. It's a slightly different, little bit less pathological. Some trans activists wish there wasn't a diagnosis at all. You can hear my bunny in the background throwing things around. But on the other hand, in order to get insurance to pay, you need some sort of diagnosis. So there's some ambivalence about this, and you have to play the game if you're a trans person and you want to get insurance to pay. I don't believe all insurance policies in the US will pay. The Danish system will pay, but you have to jump through some hoops, which you'll see when you get to next time's readings about gatekeeping. There used to be far more boy babies, natal males who wanted to transition to female. That's changing with this kind of strange phenomenon. There's a lot more female to males now, and there does seem to be some link to autism for a reason we don't completely understand with females, not with males. Politics and psychiatry, it's happening again. Transgender, you probably know this used to be called transsexualism. We don't call it that anymore. So if you believe that your body doesn't match your gender in your head, some people want to surgically correct that. Not everybody does, by the way. And there are some people these days who are like, I think I'm going to accept my body as it is. Again, that radical feminist approach would say that it's possible that if we didn't have this concept of gender, it really wouldn't matter. You wouldn't have the concept of a mismatch. Okay. And trans activists say yes, but that there is this mismatch for some people, and then that negates people who have that mismatch. Gender affirming surgery does often help for people who are trans, and this is another place where I'm trying to follow the data here rather than be political. I've read things on both sides of the aisle here. What some trans activists will say, well, that's not exactly true, but there are some people who regret the surgery and want to go back and have something different. And that's important because if you have a finite amount of resources to pay, usually you want to give it to the people who are really going to benefit. So the fact that there are a few folks who do have regret about it, that's a bit problematic. We don't completely understand that. Now, if you look at some religious websites, they will say that a lot more people have regret about it. If you look at the trans activist websites, they will say they'll lean toward 5%. So I really tried to look at everything and try to follow the science here. And I'm not sure how to think about this. Here's some, for trans man surgery, you have to surgically construct a penis. That's called phalloplasty. And generally you do that with some tissue from either their forearm or from their thigh. And you can see it here. Sometimes they have the internal organs removed, like hysterectomy, the uterus removed, and a double mastectomy. We already know how to do that for cancer, by the way. And an oophorectomy, that's when you have the ovaries removed. Trans woman surgery, that's a little easier to do. You just basically you remove the penis, but leave some of the nerve endings, and you surgically construct a vagina. You can do it really well. You might be able to preserve orgasmic capacity. And of course, breast augmentation, we know how to do that too already. Tends to be a little easier, the trans woman surgery. So what about trans youth? There is some controversy about trans youth. And let me give you an example of what the controversy is like. There's a woman who is she does a podcast called This Union in Life. She's a pretty progressive union analyst in the U.S. and she has a daughter. She had a daughter who identifies as a son, as a male now, who is has Asperger's. And when her, I'm going to call him son now, um, when her son was coming out in treatment, I don't know, he was like 14 or 15, and it was literally one day to the next. Like there was nothing, unlike, a lot of trans and also gay people, their parents, there's something about them that their parents have a suspicion. But this psychologist had no suspicion. There was nothing gender nonconforming about the child. And one day to the next, the child announces it, takes her to therapy, and the therapist says, "You have to accept this, and let's do some hormone. The treatment here is hormone treatment." And the mom, again a psychologist, was just flabbergasted, and she said she was told that you're not affirming your son, and you need to accept it and affirm him. So that's one kind of controversy. Another kind of controversy is, even with kids who you did suspect something was different about them, that, at what point can they get surgery? At what point do you give them hormones? And there's some controversy about that. I think the most one conservative approach is this thing called puberty blockers, that at least delay puberty while the child is sort of growing into their identity. Now, the idea here is that one idea is that teenagers really don't know who they are yet, and they don't necessarily have language for it. Remember, I said in the last lecture that it's possible sometimes that people think of themselves as trans because they don't really have the language yet for sexual orientation, and they're trying to make sense of the fact that they're different. And there are some kids who will change several times, before they become an adult. So, I mean, this is what I would do if it was my kid, or if I was advising somebody who had a trans kid. I would suggest the puberty blockers, delaying it while they can get into some sort of therapy group, or at least get some friends who they can bounce some ideas off of, and they try to get this who am I, this identity thing going on, because the effects of puberty blockers are relatively reversible. That's not true for necessarily hormones, and certainly not for surgery. Um, Here's something for you to think about: is what age should people be allowed to get gender affirming surgery? There are some trans people, though, who are adults, who said, you know what, I knew when I was 13, and I really wish people would have helped me. My approach, which was a little bit middle of the road, is I would do, if it was my kid, I would do everything except uh, I would, certainly let them dress how they wanted, design, call them whatever they wanted. I would get them these puberty blockers, but I would try to delay the hormones and, of course, the surgery until I felt they were more solid, or they were an adult. Um, yeah, and there's this little strange fact here that there are more, like, female to males, particularly younger kids, that are sort of that usually have an Asperger's or autistic presentation. By the way, I know they don't use the term Asperger's in the U.S. anymore, but they do in Denmark. I still use it. Um, and for some reason, there's a small population, not all female to male, but there's a portion that seem to be on the spectrum, and we don't quite understand how to think about that. This slide is just meant to show you how many different ways. It's kind of like asexuality, that there's just many ways you can be trans. This trans person here, they identify as non-binary, agender, trans woman. Their sexual orientation is lesbian. This person identifies not as trans, but just as straight female, and they call themselves an ace lesbian. That's asexual. So you can just see the wide variety of ways that people think of themselves who are trans. If you look at this person calls themselves queer and a trans man. This person calls himself straight and a trans man. Again, really breaking down all these different points on a continuum. So you all read gatekeeping and you all had a discussion post, and the point of that was just to get you to understand. I thought the gatekeeping article, it was certainly what it pointed to is that in Denmark, in trying to decide who's going to get the surgery and how they're going to spend their money, they try to look at indicators that this person will really benefit from the surgery. And one thing they've traditionally done is ask their parents, because parents, like I said earlier, often they noticed something was different about their kid. And so the parent, if the parent said, yeah, my kid was gender nonconforming when they were 5, then that was evidence that the Danish doctors needed to go ahead and pay for the surgery. But you can read in that gatekeeping articles, people experience that as discriminatory. Also, what if you're estranged from them and they won't go and be interviewed for you? So it's just extremely complicated issue in a country that I think tries to do right by trans folks, but you can hear that the trans folks here are, and also this whole thing about how you dress, like if you're male to female and you're not exceptionally female in expression, then they reported that they got discriminated against. It's just mind-boggling how many issues there are to do right by people, I think, and how complex it is. I don't feel sorry for I don't envy the doctors, is what I was trying to say. I would not want to be in their position. So this was a discussion post. I'm going to move on. The next thing I want to present you with is the American Psychological Practice Guidelines for working with transgender individuals, the APA, American Psychological Association. There's a bunch of these, and I'm going to go through them one by one, not because I want you to memorize them, but I want you to really have a sense for the kinds of things they say and they don't say. I think they're pretty good. I think they're pretty comprehensive, but you can decide for yourself. So here you go. Guideline 1, psychologists understand that gender is a non-binary construct that allows for a range of gender identities and that a person's gender identity may not align with sex assigned at birth. So really core concept here is that we understand it's not binary. Number 2, psychologists understand that gender identity and sexual orientation are distinct but interrelated constructs. The thing I keep saying to you all is that they seem to have some relationship to one another, that 7-week hormone bath, but they are still different. You know, there are masculine homosexual men and feminine homosexual women, but there seems to be some relationship that we don't completely get yet. Number 3, we seek to understand how gender identity intersects with other cultural identities of TG and C people, transgender, nonconforming. This comes from this word intersects. It comes from sociology or the theory of intersectionality, that we get that being a trans person of color is probably different than a trans person who is not of color, and that there's just all kinds of identities that can get packed together, and that they're all different experiences. Guideline 4, psychologists are aware of how their attitudes about and knowledge of gender identity and gender expression may affect the quality of care they provide. This guideline 4 gets at the countertransference. Our own attitudes will affect our care. This guideline says you ought to be aware of this. And by the way, these are guidelines, they're not rules. They're meant to be inspirational, but if you break one of these, you won't necessarily lose your license. Guideline 5, psychologists recognize how stigma, prejudice, discrimination, and violence affect the health and well-being of TG/NC people. We're sensitive to that it might be hard to be in the world as somebody who's transgender or non-conforming. By the way, none of these guidelines say that you have to work with transgender people if you don't want. In psychology, we would rather you not work with groups of people that you're not comfortable with or you don't feel like you have a competence for. What you should do, however, is have somebody that you can refer them to. So you don't have to do it, but if you do, if you choose to, these are the guidelines. Number 6, we strive to recognize the influence of institutional barriers on the lives of TGNC people and to assist in developing TGNC and affirmative environments. If you sit on the school board, you should advocate for bathroom gender neutral bathrooms. And we try to understand that the fact that there are institutional barriers that affects people when you only have a male and female thing that you can check on the form, that it can feel as though you're invisible. Guideline 7, we understand the need to promote social change that reduces the negative effects of stigma on the health and well-being of TGNC people. This doesn't say that you have to go march in the parade, but at least that you understand that there's a need for the parade and for social change. Guideline 8, psychologists working with gender questioning and TGNC youth understand the different developmental needs of children and adolescents, and that not all youth will persist into TGNC identity into adulthood. So we understand that there is a sort of fluidity in kids, and that though they may say, this is me today, that it doesn't necessarily mean they're going to be that when they're 20. We also understand it's different to work with kids like that and that they might have some special needs. Guideline 9, we understand both the particular challenges that TGNC elders experience and the resilience they can develop. They're not just challenged, but they also are resilient. If they're being forced to be in a room with another man when they identify as female in their nursing home, that could be problematic, and that's a challenge for them. Guideline 10, we strive to understand how mental health concerns may or may not be related to a TGNC person's gender identity and the psychological effects of minority stress. Let me tell you what minority stress is, though I think you saw it in the book. It's the idea that if you are a minority, that you have additional stressors placed on you in society. If you're a person of color and people in stores follow you around assuming you're stealing something, that has a negative effect on you. If you're a gay person and you experience discrimination, that has a negative effect on your mental health. Some of the early research about homosexuals was that there were poor mental health outcomes and more substance abuse, but researchers came to label this thing of minority stress, that also openly gay people have a lot more stressors than people who are heterosexual, a lot more discrimination and things that impact their mental health negatively. But we also understand that somebody trans comes into our office and they're depressed. We don't think automatically that they're depressed because they're trans. It may be completely unrelated, and we have to listen with an open mind and curiosity. We recognize that TGNC people are more likely to experience positive life outcomes when they receive social support or trans affirmative care. Trans affirmative care means we follow the client. We're specifically trying to be supportive of this aspect of themselves. Guideline 12, we strive to understand the effects that changes in gender identity and gender expression have on the romantic and sexual relationships of TGNC people. So when somebody has a gender affirming surgery, their partner might leave them, their partner may stay with them but relate differently to them. All kinds of things can happen, and we try to keep an open mind and understand all the nuance and how their relationships will change. They might not change at all. Sometimes that happens too. We seek to understand how parenting and family formation among TGNC people take a variety of forms. There is a guy named Warren. You can look him up on YouTube. He's American, but he lived in Sweden. He kept his uterus and he had a baby, so he became a dad by birthing a child. And we we don't wrinkle our nose when somebody tells us that. We have an open mind, and we just are sensitive to all the ways you can be a family when you are transgender or nonconforming. Guideline 14, we recognize the potential benefits of an interdisciplinary approach when providing care to TGNC people and strive to work collaboratively with other providers. Interdisciplinary means that we don't practice on our own, that we keep in contact with the other people on their treatment team. So, they might be working with the urologist and might be working with an endocrinologist, and you shouldn't practice completely on your own. You should, and it costs money to make phone calls and to try to go to treatment meetings. But it's good ethical practice that, I do this all the time when I see somebody who's with a psychiatrist, is that every so often I should have a communication with the psychiatrist and say, what are you seeing? Here's what I'm seeing. What is our combined treatment plan? So same is true with TGNC people, is that we work with the other doctors, nurses, etc., nutritionists, whatever, who are providing care, and that we try to provide collaborative care. That's called wraparound care. It's the best kind of care you can give. If you don't do it, that's problems. That's some ethical problems right there. So that is all I have for you today. And wherever you're viewing this from, I hope you have a good week, and I'll see you in class.